Attendees are in listen-only mode.
Hi, welcome. The Asian Health Coalition is pleased to provide you with a brief overview of our agency's Hepatitis Education and Prevention Program, HEP, which is a community-based hepatitis prevention model targeting vulnerable immigrant and refugee communities. The presenter today will be Dr. Karen Kim, Professor of Medicine at the University of Chicago and the Board President of Asian Health Coalition. This webinar will last about 40 minutes. Typed questions will be allowed during the webinar. For those of you unfamiliar with GoToWebinar, if you click the red arrow on the right-hand side of your screen, this will open your control panel. When you want to ask a question, click on the Raise Hand function that looks like a hand directly below the red arrow to alert the moderator you have a question. You can type your question in on the section labeled Questions Chat. We will hold off questions until the end of the presentation, and we will try to answer as many as possible. This webinar will be archived, and we will send a follow-up email with a link to access the webinar, as well as a short survey for you. Please make sure to fill the survey out, as your feedback is very helpful for us. We apologize to some of you for the 2 to 3 second delay on your screen. We will try to speak as slowly as possible so that this does not interfere too much with the presentation. If you are having problems with the sound, please remember you can also listen to the webinar over the phone by calling 951-266-6131, access code 179-057-164. Again, if you prefer to listen to this webinar over the phone, please call 951-266-6131, access code 179-057-164. I'll now give way to Dr. Karen Kim, our presenter. Thank you.
Hello and welcome everyone to this webinar. Again, my name is Karen Kim, and I will be speaking to you today about a community-based hepatitis prevention model for at-risk immigrant and refugee communities. As Mona had just mentioned, the Hepatitis Education and Prevention Program, or HEP, is our community-based hepatitis model targeting immigrant and refugee communities. And this program began because, like many of you, we recognize the fundamental lack of core public health services for viral hepatitis at all levels of government around education, surveillance, and treatment. However, we want to show the Minnesota audience that community-based prevention programs can be successful through community readiness and partnership building to address hepatitis B disparities. I also understand there may be folks in the audience from Hawaii, so I want to welcome those from both Minnesota and Hawaii today. The reason that we chose the Minnesota Department of Public Health is because many of the organizations and agencies that are working on the hepatitis B issue around immigrant and refugee health work together through the Minnesota Department of Public Health. But as a disclaimer, I want to make sure that everybody understands that this program is not funded by the Minnesota Department of Public Health. In fact, this is a CDC funded program that came in through the Asian Health Coalition, but we felt that Minnesota would be a strong place to begin disseminating our model through this type of webinar training. So for today, we are going to be talking about several topics, and these are our learning objectives that you should see on your screen. We're going to talk about hepatitis from global to local. Again, we're going to talk about the Hepatitis Education and Prevention Program. We want to share with you lessons learned, best practices, and successes in disseminating this model. And we really want to share with you our hepatitis community manual. And finally, to make sure that we have time for questions and answers at the end. So, hepatitis from global to local. If you look at worldwide statistics, about 350 million people are infected with hepatitis B worldwide. And I should mention that of those 350 million people, about 2/3 come from the continent of Asia. And this results in chronic hepatitis B, which is a major contributor of liver cancer and cirrhosis. And in fact, globally, 50% of all liver cancers and 30% of cirrhosis are due to infections with hepatitis B. And 80% of cancer cases result from hepatitis. So this is a disease with a huge burden worldwide. If you look at statistics, by 2030, the total cancer incidence is expected to increase by 145%, with the highest percentage of new cases among Asians and Hispanics. And this is the projection of an increase in cancer incidence by 2030. I certainly know that when I saw this slide, I was really surprised by the high rates of cancer increase in among the Asian and Hispanic community. In the United States, about 1.5 million people are infected with chronic hepatitis B. And what is very disturbing about this is that 75% of those who are infected do not know they're infected. About 50%, or 1 out of every 2 people infected with chronic hepatitis B, are of Asian American Pacific Islander ethnicity. And 65% of all Asian American Pacific Islanders are foreign-born, bridging the global burden of hepatitis B from Asia directly into the Asian American Pacific Islander community. In terms of looking at prevalence of chronic hepatitis B worldwide, the United States is shaded in gray, which shows areas of low endemicity or low prevalence of hepatitis B surface antigen, the component that we look at to determine if someone has chronic hepatitis B. But if you look at other areas in the world, particularly in Asia, Sub-Saharan Africa, you see that there's high levels of hepatitis B shaded in by the black or dark green color. In fact, if you look at worldwide prevalence of hepatitis B, almost everywhere short of the United States is a higher prevalent area. And according to CDC guidelines from 2008, these are the areas that need to be heavily screened. As I mentioned before, from global to local, if you come from an area of high prevalence into the United States, you bring those risks with you as you live in the country. So although the United States overall is low endemicity, immigrants and refugees from countries that come from higher endemicity are certainly at risk and need to be screened. Let's look at Asian Americans in Minnesota. Minnesota has over 215,000 Asian American Pacific Islanders. There has been a 52% increase since 2010. Over 60% are foreign-born, and a majority of Asian Pacific Islanders in Ramsey County are limited English proficient, and 42% in Hennepin County are limited English proficient. Asian American Pacific Islanders in Anoka, Dakota, and Scott counties all have limited English proficiency rates of a third or more. And as many of you know, this tremendously impacts the ability to deliver culturally competent and linguistically specific care, which is a big problem in working with these communities. In terms of persons living with chronic hepatitis B in Minnesota by race, looking at rates, you can see Asian or Pacific Islander in orange, African American, Native American, Hispanic, and white represented in blue, and you can see the huge burden of chronic hepatitis B among Asian Americans living in Minnesota. Now we're going to turn to talk about the Hepatitis Education and Prevention Program, which we call HEP. This is a program that was developed by the Asian Health Coalition, and this coalition was founded in 1996 with a mission to improve the health and well-being of Asian American Pacific Islanders in Illinois through advocacy, technical assistance, education, and community engaged research. Also to address health disparities affecting Asian American Pacific Islanders, identify their causes, and develop strategies to reduce them. And finally, to develop best practice models to improve community health, which can be replicated and scaled, such as our HEP program. In order to do this work, though, we could never do this in isolation. We have developed over the course of years numerous community partners that are listed here. It's also important to know that we have worked with several organizations that also have similar problems that are not from the Asian community, such as the Ethiopian Community Association of Chicago, And we have worked with these partners to conduct screenings to adapt the HEP model to communities that share similar backgrounds as the Asian American community. In terms of the HEP program, I'm going to list for you several of our objectives. And in terms of how these objectives played out, during year 1 and 2, we focus our efforts on goal 1, which is to build infrastructure and capacity. And activities for this included providing training for all community health workers to prepare them to recruit and educate their community on hepatitis B and to lead individual participants into medical care. During years 3 and 4, we focus on increasing hepatitis screening rates with large-scale events organized and carried out with the assistance of community health organization or medical professionals, and always accompanied, and all of our screening programs were accompanied by culturally tailored hepatitis B education. At the end of the year, year 4 and 5, we collected all valuable feedback from what we documented through the first 4 years in order to develop a comprehensive best practice hepatitis manual. And during our webinar 2, we will go into more detail on tools available that are described in the manual. In terms of our model, you can see displayed on the screen right now several steps in the model. We began by recruiting and training community health workers, for the community health workers to provide outreach and education, and for community health workers to also help us with screening referrals. From this, we were able to develop hepatitis education and screening events, and also to begin working with our providers, who are the necessary step in our Linkage to Care program. Through our screenings, we determined if our communities were susceptible to hepatitis, were themselves carriers, or immune, and from there we were able to develop community health worker assisted vaccination programs for those who were deemed susceptible. We were able to do follow-up referral and treatment for those who were in need of treatment, and for those who were immune, we did not take on any further action. In terms of the dissemination phase, the final year of our CDC cooperative grant, we are sharing the results of our hepatitis B manual model by several mechanisms. One is through the development of a HEP manual that I hope all of you will take a look at. We have developed information on our website. We are providing webinars such as this one, which is our first webinar that we're hosting today, and have done a series of provider presentations across the United States to really help to make sure that both our providers as well as our communities are in line with understanding the goals and the need for screening and treatment for those at risk for hepatitis. I'm now going to talk a bit about our best practices, our successes, and some of our lessons learned, because I think by sharing both our successes and challenges, it'll help to disseminate this model in a more meaningful way. Some of the methods that were found to be effective when working with limited English proficient immigrant and refugee groups included recruiting and training bilingual, bicultural community health workers to conduct culturally sensitive and language concordant education and outreach. From experience, we learned that community members react best to those from the same background and may understand the cultural and linguistic gaps they face as immigrants. Because of the way our community health workers connected to the community, our participants are more likely to attend a screening event and fully participate in education and screening. Partnering with trusted and established community-based organizations which serve Asian immigrants and refugees to be primary venues for conducting health education and screening has been a very important lesson that we have learned. And establishing relationship with providers, either small groups, family physicians, federally qualified health centers, and hospitals, serve as pathways to connect those chronically infected with hepatitis B and those in need of hepatitis B vaccination. Because the population we work with are particularly disenfranchised from the medical system, it is important for us to provide the full continuum of care, from screening to linking them with specific providers. And I can't emphasize the linkage to care component enough, because it's not good enough just to screen if you cannot send those patients into care. And that's why our model with linkage to care through culturally competent providers is something that really is an important component. I'd like to share some of our successes. This is looking at activity from 2006 to 2011. The Asian Health Coalition has developed a proprietary database to collect information and has been developed in terms of reporting templates that are publicly available. We can share this in more detail for organizations interested in technical assistance, and we will talk about this more during our webinar too. This is looking at people educated, number of group educations, number of health fair events, number referred for screening and immunization, and adults screened. And you can see over the course of the last 5 years, there have been really robust numbers, from 32,000 people being educated to over 2,000 individuals being screened. And this has been a really tremendous group effort in order to come up with these robust numbers. In terms of lessons learned, it's important for us to go back to talk to our different community health workers to understand what are some of the things that the HEP program has provided for them in their communities. One of our Cambodian community health worker stated that most clients are so happy that we provided brochures in our language, especially the liver in color. We can show healthy liver, fibrotic liver, cirrhotic, and liver cancer. One of our community health workers from the Lao community reported that my happiness comes from taking care of people. That's my Buddhist upbringing. Another community health worker from the Lao community reported, I like to tap into our cultural traditions to promote good public health measures. And our Korean community health worker reported that through the individual education, most clients realize the importance of hepatitis B. Many of them did not know whether they're immunized or not. And these are words that are really important to us because, in fact, our community health workers are representing the communities that we're trying to serve. Again, I would love you to look at our our hepatitis community manual, which is now online, and those resources will become, at the end of the presentation, we will provide links to be able to look at these resources. In terms of specific tools and resources that were used to develop the community partnerships and to conduct screening and outreach events, these will be covered in more detail on webinar 2. But in terms of online access, you can see now on your screen the website for our manual. If you also look, you will see tools for community health worker training, outreach samples and templates, screening and vaccination tools and resources, and additional lessons learned and best practices. Again, I encourage you to visit our website. In terms of webinar 2, which will go into more details, this will be held on May 9th, 2013 at 3 p.m. Central Standard Time, and specific content that will be covered on this webinar will include capacity building, specifically looking at community-based organizations, capacity building in terms of community health workers, and capacity building in how to link and identify providers that can work with you to help navigate the system for these often linguistically isolated individuals. I would also like to say that even during gaps in funding, we meet with our partners to provide education and resources for current issues related to hepatitis. We plan to continue to disseminate this model as well as to advocate for more policy-level work for hepatitis. The Asian Health Coalition is available to provide technical assistance and consultation for those interested in replicating all or part of the model. And you can contact us. Mona El Shama her contact is listed on your screen right now. We'd really like to help to answer questions, to make connections with other partners, and for further discussion on tools that can be available on our website. At this point, I'd like to open up the floor for any specific questions, or comments about the webinar, you can also see a list of resources or sources on your screen at this point in time.
Okay. You are still welcome to type any questions that you have, but we will also unmute all attendees so that you're welcome to ask questions. However, in order to avoid background noise, please mute your own computer and only unmute it when you'd actually like to ask a question. Thank you.
Are there any questions? You're lucky that I can't see you, because if you were in my class, I'd call on you. So are you sure there are no questions?
I have a question.
Yes.
Hi, should I type it?
Oh, you're getting a lot of echoing.
Again, please mute your own computer, and only if you have a question, then unmute.
Type the question. We're getting a tremendous echo.
Muted. Unmuted.
And then, okay, I'm going to re-answer the question just because it looks like there was some technical difficulties. So the question again was, can you speak a little more about the selection of community health workers and how they were sustained in terms of stipends? So we have partnerships with about 25 community-based organizations in and around Chicago, and we work closely with them to identify either existing staff or people that they can bring on board who are personable, who have great connections with the community, who are kind of champions for health, who people always go to for questions, and the community, kind of little mayors of the community. And we bring them on board by training them, which we'll talk more about on webinar 2. We train them. We train them and provide them with skills on how to be community health workers, and then we do provide stipends for them. So the stipends range in amounts. So sometimes, it just depends on our grant, and anyone who has a very specific question about how much we pay them, feel free to contact me after. But yes, we do provide stipends for them.
And I should also add that part of the ability to develop capacity of communities to take on this program is that we only really work with community health workers that are already networked through a broader community-based organization, often that have not only health but social services associated with it, because we find that this allows us to develop a more sustainable program going forward, and that's a very big component of how we could choose our community health workers. Let me see if there are any other questions. There's another question. Where or how do people who are screened and test positive receive follow-up care? I think that's an incredibly important question. You know, there are many programs that do community-based screening, but without a linkage to care, we certainly know that many of those individuals who are screened positive then struggle with having the ability to get any type of follow-up. So our HEP model has developed a linkage to care program with either federally qualified health centers and with our county system to make sure that we can provide linguistically specific services by targeting specific physicians who have been integrated into the HEP model from the start. So we worked with our local departments of public health and our hepatitis B advocates, as well as leadership from our safety net systems, to make sure that we would have a place to send our patients after they got screened. We also convened a physician advisory group that agreed to allow us to send patients to their facilities in the event that somebody screens positive. And also we were able to work with local physicians, community physicians, who agreed to see our patients that ended up becoming screen positive. Another question is, are there any issues with stigma around hepatitis B that make outreach difficult? That's another good question, especially when we are screening individuals that are often foreign-born immigrants who come from countries where there is large amounts of stigma associated with hepatitis B. We have not had problems with stigma largely because we have worked through trusted not only community health workers but community-based organizations that are often the social service agencies that have worked with new communities as they come in to the area. And so we have done all of our screening events for the most part in partnership with community-based organizations who help bridge that trust gap. In terms of stigma, this has not been something that has been a problem in screening. What has been a problem is the thought from a lot of community members that there is no good treatment for hepatitis B. And so that idea about why get screened if there's nothing we can do about it. And that is why all of our screening programs are paired up with a very short but important educational program as a ticket to screen. Another question is the linkage to care model similar to ARTAS at all? Do you think that ARTAS model could be used in HEP linkage to care? So whoever asked that question, it may be a great question, but unfortunately I'm not familiar with the ARTAS program.
So to the person who asked that, if you could please, I'll make sure to contact you. I know who you are, so I'll contact you and get a little more information about this, because we're always welcoming more resources and information.
What we also might be able to do is summarize this list of questions and put it on our website, so once we do get the answer to this question, we can link it. Okay, another question is, are there some screening community locations that are more successful? Boy, that's a good question. Maybe I'm going to ask Mona to see how you might answer that.
So traditionally, we have held our screening events at community-based organizations who already have kind of a presence in the community, relationships with community, and that has tended to work out really well. We recently received
They're talking about
um, we recently received another CDC grant that in which we're screening about 1,500 people this year, and that has allowed us to kind of branch out and hold screening events at places that we normally wouldn't. This past Saturday, we were at a health fair with over 300-400 people, and we were able to screen about 35 people. However, it was an interesting event because it was a health fair, so we didn't provide our regular education in the normal fashion we do, which is a presentation. But we were able to have one-on-one conversations and have a lot of culturally and linguistically tailored material. And so we will let you know a little more about what's working better. Traditionally, we believe that having it at community-based organizations that have established presence in the community is probably safest and it helps with linkage to care.
I think the other point is that probably the best place for a screening would be in a community health center. Unfortunately, at least in Illinois and probably in many Midwest areas, there's no community health center that sort of serves really large numbers of Asian populations, and as a result, if you hold a screening there, it's not cost effective and you actually don't capture that many patients. And so again, doing screening without linkage to care is really not an ideal goal, so you need to work with an organization that's connected to a healthcare system. So next question is, you mentioned that Minnesota Department of Public Health was involved with this project. Has there been any talk about introducing similar programs in Minnesota?
Mm-hmm. So I just wanted to clarify that Minnesota Department of Health has been very generous in promoting this webinar, but they're actually not so much involved in this project. They're not funded. They only were here to promote. So I can definitely speak to our contacts there and provide you with some more information about if there is talk of similar programs in Minnesota.
Another question is, for those foreign-born who are ineligible for Medicaid or other insurance programs, how do you link them to care and treatment, especially for monitoring blood work and labs? Well, this is a really important question and has been a constant challenge. So what we have done is, at least in Chicago, is that we have worked with our safety net system to provide services, including blood work. We have something called a core, a program that provides treatment for those who are usually co-infected with B and C and HIV, but we have been able to work with them to agree to treat mono-infected hepatitis B patients. They develop some type of sliding scale program, but certainly take people who have no insurance. And so we've been able to develop that linkage, which has been very, very important for our population and communities. Another question is, when will we have a rapid hepatitis B test for commercial use? That is a great question. I think it's something that we really need to develop, similar to the way hepatitis C has an in-office test. I think that this should be done. We know that we have the technology, so we're hoping that this will become commercially available very soon, but at this point we do not have that test available. Okay, any other questions before we wrap up? Oh, here is another question. What are the barriers or challenges of applying this model? I think the biggest, so this model, we started developing this model in 2001, and we are now at 2013, so this has been a 12-year work in progress. And over the last 5 years with funding from the Centers for Disease Control, we were really able to sort of galvanize the program and support it through sort of sustainable funding. And I think the biggest challenge in the beginning is it's easy to do community screening. It's very difficult to find a linkage to care program. It's also very challenging to be able to train community health workers that are able to help bridge the divide between an institution and the community. And so to be able to develop community health worker training modules and to develop sustainability of those individuals to be able to work with us over the course of the year has been a big challenge, but one that we've been able to overcome pretty well. I think the biggest challenge is starting HEP in an area in the Midwest where we do not have a good, when we don't have good infrastructure for Asian health. The biggest challenge is developing linkage to care and sustainable linkage to care. So what will happen under Affordable Care Act may be interesting, although as many of you know, as it currently stands, hepatitis B screening will not be covered as one of the preventative services under Affordable Care Act, so we hope to change that. But we do hope that once somebody is identified with hepatitis B going forward, that treatment will become available. Okay, so again, we hope that this has been helpful. Again, this is just, this webinar was really to introduce you to the model, and our next webinar, which is going to be on May 9th, we will get into much more detail in terms of capacity building for community health workers, physicians, and community-based organizations, and we hope that you'll be able to join us for our second webinar. So on behalf of the Asian Health Coalition, I'd like to thank you for joining us, and I'd also like to do a shout-out thanks to the Minnesota Department of Public Health for joining us in helping us disseminate this first program. Again, thank you all.
I'd also like to put in a little plug to please complete the survey that we send you. It'll really help us as we continue to develop more webinars, and any feedback is very helpful. Thank you so much.
How was that? Awesome. Okay, let me make this one. Yeah, I should have gone more into detail about something, but it's okay.